Yes, we can.
Thank you. So I am going to present the phase 1 results of a phase 1/2 UNMC institutional trial for patients with newly diagnosed anal cancer treated with concurrent radiation therapy, 5-FU, mitomycin, and BMX-001, which is a normal tissue radiation protector. So anal cancer is not very common, and there are about 8,600 new cases and 1,350 deaths from the disease in 2020. And over 80% of anal cancers are squamous cell carcinoma, and risk factors for anal cancers are typical use, multiple sexual partners, a history of HPV virus infection, and a history of chronic immunosuppression. Current standard treatment for locally advanced squamous cell carcinoma of anal cancers is combined modality therapy with radiation and concurrent chemotherapy with 5-FU and mitomycin. So Dr. Kachnik did a very good job in this part. So I am going to move into my study soon. So this regimen actually allows organ preservation in approximately 75% of patients, and reserving the APR for as a salvage surgery for patients with persistent or recurrent disease. The use of this concurrent chemoradiation therapy regimen results in local regional relapse rates of 20 to 32% and 5-year relapse-free survival rate of 47 to 68% and 5-year colostomy-free survival rate of 47 to 72% and 5-year overall survivals of 58 to 78%. So although this regimen actually produces a high cure rate, the treatment toxicity are high. So these tables shows the toxicities associated with the regimen of RT concurrent with 5-FU mitomycin in RTOG 0529 and 9811 trials. So non-IMRT techniques was used in RTOG 9811, and IMRT technique was used in RTOG 0529. If we categorize toxicities by organs, acute grade 3 and higher skin toxicities were about 23% in RTOG 0529 and 49% in RTOG 9811. And GI 21% in 0529 and 36% in 9811, GU 2 to 3% and hematologic toxicity about 60% in both trials. Overall, both trials have over 80% toxicities. So, so in order to decrease the acute and late toxicities, clinicians have used amifostine in the past. Although this agent is approved by FDA for this use, its daily use is limited by its side effects. So some other agents are not currently approved by FDA for this use. So recently, manganese porphyrin-based compounds have been developed as radioprotectors. These compounds are potent anti-inflammatory agents, catalytically inactivate a range of reactive oxygen species, and these compounds were found to be able to protect normal tissues while also augment tumor killing in patients undergoing radiation chemotherapy. And Dr. Deegan's lab has done a lot of work in this, and she presented her data. So you understand everything before I give you this presentation. So BMX-001 is among the most highly potent in this series that have been evaluated thus far. So in our study, we hypothesized that BMX-001 will decrease chemoradiation-associated toxicity without compromising the survival outcome. And the objectives of the phase 1 portion of this trial were to determine the MTD and affinity of the BMX-001 primarily, and secondary also evaluate other outcomes. Endpoints, including toxicity and quality of life, were assessed with CTCAE and EORTC questionnaire C30 questionnaires respectively. MTD was defined as the highest dose level at which no more than 2 out of 6 experienced dose-limiting toxicity. And definition of dose-limiting toxicity, the DLT period includes from the start of BMX-001 through 4 weeks after chemoradiation treatment concludes. And DLT was defined as any of the following events that are at least possibly, probably, or definitely attributable to BMX-001. And we have a non-hematologic as a whole list of dose-limiting toxicity, and also we have a hematologic dose-limiting toxicity, and including any toxicity, any grade of toxicity that we cannot resolve it within 14 days, that's also listed as a dose-limiting toxicity. So this is the study schema, and we have 3 drug levels. First dose level has a loading dose 7 milligram per subject, and the maintenance dose 3.5 milligram subject BIW, just twice a week. And level 2 is a 14 milligram per subject, and with the maintenance dose of 7 milligram per subject. And dose level 3 is 28 milligram per subject with a maintenance dose of 14 milligram per subject. So, okay, so this is the detailed study schema. So everybody is getting 2 times a week, Monday and Thursday, and subcutaneously. Okay, so let's move down to the next one. So this is our sample VMAT radiation treatment planning. The yellow line is 54 gray, the green line is 45 gray, and the dark red GTV plus a small margin to the blue line was finally boosted to 59.4 gray. And I want to mention a little bit, because this is a phase 1 study. Initially, I was going to mimic RTOG 0529 to do all different levels of those, and our IRB did not allow me to do that because that will confuse the study result, because if we have multiple dose levels, so we have to use only 1 dose level just for this study purpose. Okay, so this table shows patient characteristics. We have, actually we have accrued 12 patients, but we only have 11 patients now. We can analyze it. Median age 61, male-female ratios 3:8. Median size of primary tumor was 37 centimeter, 9 out of 11 with positive notes. BMX was dose escalated from level 1 to level 3. Most of the patients received 12 doses or more, and 1 patient actually was off study after 2 doses. 1 out of 11 patients declined the 2nd cycle of chemotherapy, and the radiation dose, we talked about it in the last slide. So we accrued 3 patients for level 1 and 2, and 5 patients for level 3. We did have 2 patients who were so anxious that they increased their blood pressure prior to having the injection of BMX. 1 patient had increased the blood pressure 30 minutes after BMX injection. 3 patients had allergic reactions to the first dose of BMX with injection site reaction, hypotension, hives, and tachycardia. 1 patient allergic reaction subsided without treatment, and 2 patients required Benadryl and hydrocortisone. So since then, we modified protocol to pre-medicate every patient with Benadryl to prevent allergic reaction. So far, we have had pre-medicated patient 11 and 12, no allergic reaction was seen. Okay. So let's look at the acute hematologic toxicity. We observed the grade 3 and 4 acute hematologic toxicity during chemoradiation, including 1 grade 4 decrease the platelet count, 2 grade 4 decrease the lymphocyte count, 6 grade 3 decrease the WBC count, and 2 grade 3 decrease the ANC count. When we use the worst grade patient count, we have 3 grade 4 and 6 grade 3 hematologic toxicity. When compared to RTOG 9811, it seems that we have more grade 3 hematologic toxicity, but the trial is still going. We are going to accrue 20 more patients in phase 2 trial, and then we'll see what happened because the number is still low right now. Okay, so for non-hematologic toxicity, we observed no grade 4 toxicity, 2 grade 3 dermatitis, and 4 other grade 3 toxicity. When we used the worst grade patient count, we observed a 45% grade 3 non-hematologic toxicity, which is much lower than the grade 3 toxicity in RTOG 9811, and we don't have grade 4 toxicity in RTOG 9811 had 13% grade 4 toxicity. Let's go to the next slide. Okay, so when we compared the toxicity of the skin, GI, and GU in this study with RTOG 0529 and RTOG 9811, we have much lower grade 2 plus or grade 3 plus toxicities in each category. And this table basically want to show you that the toxicity actually resolved very quickly. The skin, GI, and GU toxicity very quickly after 1 month follow-up. And the pain also resolved with time. By 10 months, no patient with any pain. And we also evaluated their physical functioning that use EORTC C30 questionnaire. And by answering all these 5 questions, and these curve was calculated with that answers. And you can see that their physical functioning actually decreased to lowest point at week 6, which is right after the 2nd cycle of chemo. And then they recover rapidly. By the end of 10 months, they basically close to normal. And we have here, so this is actually physical functioning of general population provided by EORTC. And our patient population actually has a median age of 60. So you can see that median age 60 of general population score is close to 90. So you can tell that these patients actually, when they are sick before the treatment, their physical functioning was low already, lower than the general population. But then after the treatment, actually they improved to reach to the general population. And we also did the role functioning. Similarly, we see this dip after the 2nd cycle of chemo. And again, this is calculated by patients answering these 2 questions. Again, you see the drop in the beginning of at the time of diagnosis before treatment. And we also compare this to the general population. it's supposed to be about 80 something. So they did recover to the 80. And then we do the emotional functioning. That's much less of a change here, but you do see a little bit dip. And the cognitive functioning, that's actually not too much change, because if you compare this to general population, that's about the same. It's about 85. So, and then social functioning, a big dip and then recovering. So quite similar thing. And then fatigue. This is actually, my curve is normalized, and this general population is not, so meaning you have to use 100 minus this 20, so it's supposed to be, in my curve should be about 80 is normal. So you can see that fatigue also recovered after the treatment. And the nausea, vomiting, slightly dip and then recovering. And also pain. Not so pain after second cycles of chemo and then coming back to normal. Dyspnea, that's probably because of anemia, and you see slightly dip, and then insomnia, then appetite loss, and then constipation, actually no dip, it's actually with treatment it's getting better. And diarrhea takes very long to recover, and actually by 10 months, it still have below the normal. Financial difficulties also has a big dip. And then global health status, with these two questions, you can see that the same kind of pattern. And finally, we have a QLQ summary score by adding all these 13 subcategories and divide by 13, and that's you can see that that's the dip. Okay, in conclusion, BMX 001 MTD was reached at level 3, because we do have a grade 3 platelet decrease. So that's a DLT we defined. A loading dose of 28 milligram and the maintenance dose of 14 milligram concurrent with chemoradiation is recommended for phase 2 trial. And current CTR BMX was associated with a concurrent CTR BMX was associated with a decreased acute non-hematologic toxicities, including skin, GI, and GU toxicities compared to RTOG data. The decreased QOL of patients during CRT returns to pre-CRT status in about 1 month. With a median follow-up 22 months, all our patients are alive and without evidence of disease. So this abstract has been accepted by ASTRO 2021 for quick pitch presentation. Thank you very much. This is the end of my presentation. Let's move into